And it is my extreme pleasure and honor to introduce the Perlmutter Lecture this morning and Dr. Tamara Simon. Today is the fourth annual David Perlmutter Research Lecture. Every year we honor our previous chair, Dr. Perlmutter, by bringing a biomedical researcher to share updates in his or her field. Today we have Dr. Tamara Simon speaking with us on inpatient care of children with medical complexity. Dr. Perlmutter is a profound researcher in pediatrics, and we believe he would be very excited to hear about the new research developments we highlight with this lecture every year. Tamara Simon, MD, MSPH, is a pediatric hospitalist with a research focus on improving the quality of evidence in inpatient healthcare provided to children with medical complexity. Since April 2020, Dr. Simon has held numerous leadership positions, including faculty in the Division of Hospital Medicine in the Department of Pediatrics at the Keck School of Medicine at the University of Southern California, member of the hospital medicine team at Children's Hospital Los Angeles, and principal investigator at the Sabin Research Institute of Children's Hospital Los Angeles. Dr. Simon's main clinical research focus is on cerebrospinal fluid shunt infections and reinfections in children with hydrocephalus. She has been an active investigator in the Hydrocephalus Clinical Research Network since 2007. Dr. Simon's health service research focus is on improving the quality of care provided to children with medical complexity in the inpatient setting. Dr. Simon's contributions to research in the field of pediatric hospital medicine have garnered national recognition. In 2018, she was the recipient of the Outstanding Research Award in Pediatric Hospital Medicine, election to the Society of Pediatric Research as an at-large member of the Council in 2019, and induction to the American Pediatric Society in 2019. Dr. Simon is passionate about the mentorship she provides to residents, fellows, and junior faculty with specific research interests in hospital medicine and other generalist fields, specifically those interested in physician scientist career path in this growing field. She parlayed her passion for mentorship into a leadership role as faculty director for training, education, career planning, and development, and associate director for training and education within the Sabin Research Institute of CHLA from 2020 to 2022. Dr. Simon now serves as CHLA Principal Site Investigator, Workforce Development Director, and Co-Director for the Southern California Clinical and Translational Science Institute, their version of our CTSI. A member of the editorial board of Hospital Pediatrics since 2010, Dr. Simon has been an associate editor since 2014. Dr. Simon also serves as a grant reviewer for NIH and various foundations. Please join me in providing a warm welcome to Dr. Simon.
Thank you so much. It is such a privilege to be here today. I am so impressed with your city. So I had the privilege of flying in last night and came in through the tunnel and just was blown away by a fantastic sunset. And it's a wonderful, beautiful children's hospital that you have here today. And I'm really excited to be here. I'm also really have a just complete joy when I get to give this talk. I first gave it in 2020, and it afforded me the opportunity to take a look back at what has happened in my career, which has really developed alongside the development of hospital medicine as a subspecialty, but also sort of simultaneously reflect on developments in complex care, which I think is, in my mind, is sort of an emerging, I don't know if it's officially a subspecialty, but it's certainly a focus area in pediatrics. And this talk has really afforded me the opportunity to reflect on being sort of on the cutting edge of a wave. I sort of think a lot about, now that I live in Southern California, my experience surfing, and I sort of feel like I get to be out in the water, and I get to see a whole lot of other people riding the waves coming in. And this talk is a way of really celebrating them. So thanks for the opportunity to share my thoughts today. Nothing that I say reflects the opinions or views of Children's Hospital Los Angeles. All of these opinions are my own. And I'm not aware of any relevant financial relationships that require disclosing. Thank you, Dr. Miller, for your kind introduction. I will skip over a lot of what I was going to say because you've so adequately covered it, but I have had the privilege of a lot of leadership opportunities within my own research teams, as well as infrastructure-wise at Children's Hospital Los Angeles, as well as our Southern California Clinical and Translational Science Institute. And if anyone has any questions, I'm always happy to opine on those experiences and share more. By the end of this session, I'm hoping that all of you will be able to summarize the impact of children with medical complexity on delivery of inpatient care to children, describe specific clinical considerations in the inpatient care of children with medical complexity, and as I sort of alluded to with my surfing analogy, explain emerging research that will impact the inpatient care of children with medical complexity. So again, we will cover each of these objectives in sort of each of three parts, and I'll share some closing reflections and then open it up at the end for some questions, if any arise. So I'm going to start with sort of taking you back about 15 years now to summarize the impact of children with medical complexity on delivery of inpatient care to children. Do I need to do something? Okay. Sorry. So I am taken back to sort of being in the room in about 2010 with some of the thought leaders in the field. And I think we were acutely aware that we were standing on the shoulders of giants. We were all hospital-based pediatricians. We felt like we were taking care of some really, really tough children to take care of, not tough children. But we felt like there was, while there was work that was being done in the field describing the kinds of kids that we were taking care of, there was a lot that was lacking in literature as well. So I remember distinctly, at the time, the conversation that we were having was about this definition of children and youth with special healthcare needs. So these are children who have or are at increased risk of a chronic physical, developmental, behavioral, or emotional condition and require healthcare or health-related services of a type or amount beyond that required by children generally. And this was just sort of the feeling in the room that this was a really important definition. It was the underpinning of a lot of policy decisions and really critical for defining an important population of children that needed services from a policy perspective, but they weren't really the kids that we were taking care of in the hospital. So we sat around the room and wrung our hands talking about these children. Child first terminology or person first terminology was hot at the time. So we moved past calling them medically complex children and into sort of this terminology of children with medical complexity that I'm using throughout my talk. And these really are, of course, the subset of children and youth with special healthcare needs with the most extensive medical and functional needs. But we wrestled with this definition. And again, these were some of the folks that I think about when I think about this time. And really, I remember distinctly sort of the collective of us having imposter syndrome, like who are we to be talking about this population? And I just remember being like, I think we should write a white paper and we should really put this out there. So I'm proud that we did that. And we have put forth in this paper, and I think this has underpinned a lot of discussion of 4-domain framework. So sort of who are these kids? Well, they're children who are at increased needs. These needs are substantial. They tend to be family identified service needs, and they tend to have a significant impact on the family. Financial burden is sort of a piece of it, but I actually think that it's probably more accurately characterized as a caregiving burden or privilege. I think it probably goes without saying that these are children who have chronic conditions. At the time, there was sort of actually a paucity of ways to identify these kids. I'll go into the plethora of approaches that have sort of followed. But I think it's also important to recognize, and I think you all have a legendary diagnostic clinic that sort of deals with the unknown or the suspected, the kids without a label, but who are seeking a diagnosis. And these conditions are severe, and they're associated with medical fragility. So it's not just the label of sort of having this condition, but it's again, sort of the intensity of these conditions. These are often associated with functional, thank you. I'm sorry for all the AV issues. I'm a low talker, so I bear full responsibility. So the functional limitations follow. They tend to be, as I've already alluded to, severe and often are associated with technology dependence. And of course, as I've alluded to a lot, these are children with high resource utilization. Often in the inpatient setting, as those of us who were hospital-based providers recognize, but also, and I think functionally speaking, more importantly, requiring the involvement of multiple subspecialty and not just subspecialty physicians, but sort of ancillary service providers. And at least from where I sit, it took me, these were kids I could not stand taking care of as a pediatric resident. I couldn't wait to be done with taking care of the purple team kids. These were the kids that were at Children's Colorado, where I trained. They were sort of just the bane of my existence as an intern. And the story I like to tell is that in order for me to stay in academics, which I knew I wanted to do, and work on building up my research skills, I needed to do an academic, general academic pediatric fellowship, because we did not have hospital medicine fellowships at the time. So the only way that I was allowed to function as a hospitalist at Children's Colorado at the time was to agree to take care of the purple children who were in the inpatient setting. And I'm so grateful that sort of the universe forced me to revisit these kids as a fellow, because I sort of came to understand the tremendous privilege that it is to think of myself as a quarterback for a team that involves the patient and the family and all these multiple providers, and sort of really came to reframe the involvement of these multiple providers as an opportunity to sort of really ground in care coordination principles and in shared decision-making principles. So again, this paper really laid the groundwork for sort of an emerging high need population that requires intensive care. At the time, it sort of identified this definitional issue. It recognized that the existing care models don't fully meet the needs, and that we really needed to promote research focused on child, family, and system outcomes. As I was sort of preparing for this talk, I realized that probably, even though it's been 15 years, I think we could probably make a case that a lot of these key priorities still remain the same. So I think we've definitely made some forward progress, but there's still lots of work to be done. So why do these kids matter? This is sort of a seminal paper that I had the privilege of writing sort of simultaneous to another group that Catherine Burns led. This is data that was using the KID database, which is representative of children's hospitals across the country. And this data, while really old, isn't really dramatically changed. We sort of demonstrated that while about 10% of the population of hospitalized children, these kids were taking about 25 to 30% of hospital days and about 40 to 50% of hospital charges. This data has been sort of replicated over and over without dramatic differences, and with a myriad of algorithms, which I'll go into. But the bottom line is the principle remains a relatively small number of children that are, again, have sort of outsized resource utilization. So it sort of made sense, and increasing, these tails go up. And this has sort of remained true over time. I wanted to give a shout out to my colleague, Nama Huja, who was at Children's Hospital LA until very recently. She did some nice work that demonstrated, and this was sort of taking an approach of technology dependence, that made a case that these, while I'm totally guilty of being a tertiary or quaternary care hospital person. I think about these children from a sort of a very specialized hospital perspective, but these are children that are being cared for across all the all hospitals, children's hospitals or otherwise around the country. So I think she made a really distinctive case that we should be caring about these kids and not just from the ivory tower. I've alluded to this already, and for anybody who has even a glancing familiarity with this field, the last decade or so has resulted in a plethora of algorithmic approaches to identifying these children. I think for about 10 years, I think every conversation I had when I went to a national meeting was, I'm trying to do research in this area. Which of these algorithms should I use? So the work that I showed you was using sort of the old algorithm, or the original OG, I guess I should call it, algorithm of complex chronic conditions that Chris Feutner developed. We spent a lot of time in Seattle developing, with the input of general pediatricians, a more generalized type of algorithm. We called it a pediatric medical complexity algorithm. And then there's all kinds of folks who have put out codes for neurologic impairment, the SWIDA, or children with disability algorithm, technology assistance. And again, I think There's a lot of data sources, variability in data sources. I think my take-home message whenever I talk to people who are thinking about using these algorithms is go back to thinking about the quality of your data, where is your data coming from, and what is it that you're trying to identify. So my extraordinary simplistic take-home message is sort of go back to first principles, understand a little bit about what the algorithm was intended to identify, recognize that these are probably overlapping dimensions of this bigger elephant that we're trying to describe of sort of children with medical complexity, and sort of apply, proceed accordingly. So the next decade, I like to say, has resulted in a just deluge of papers describing, again, between the combinations of those algorithms and then sort of increasing access to data, better and better, or more complete, more comprehensive data sets. A ton of papers have been coming out. So we sort of have been able to move out of just hospital-based data, for example, studies using HCUP KID and FIS, and into sort of more Medicaid-based data, and sort of EMR-based data, and we're sort of getting broader and broader visibility to the care that these children are receiving sort of across the care spectrum. I'd like to sort of call out my friend and colleague Eyal Cohen up in Canada because, of course, being Canadian, they had access to sort of broader data that reflected utilization across, in this case, the province of Ontario. I like this paper too because it gives you a little bit of a flavor for all of our algorithms that we love in this area, with NI for neurologic impairment, TA for technology assistance, CCCs. But I think this pretty simply illustrates that no matter how you choose to approach or identify these kids, you're going to find kids who are at higher risk of mortality, kids who are having lots and lots of readmissions, and not surprisingly, elevated home care use, elevated medications. And I think you can kind of get the sense with the outpatient use, just the enormous number of visits that these kids experience, both to primary care and subspecialties. So there's no question we are seeing these kids, and it's nice to have some numbers that reflect this. I'm super excited that my friend and colleague Joanna Leonard, who's at Dartmouth, has finally been able to sort of accomplish what I considered a little bit of a holy grail. I was always like, that's fine to have Canadian data, but we should really have it for the US. So she was able to get an R01 and use the tremendous machinery of Dartmouth and their data access to look at all payer claims data across 3 states. So I think they're a little bit of a strange combination of like Massachusetts, New Hampshire, and Colorado. But she's been able to, with support from NIH, do similar sorts of studies. So again, apologies for the inside baseball around sort of all of these algorithms, but here again on the right side, you can see the complex chronic conditions stacked up against PMCA, stacked up against the children with disabilities algorithm. But again, in sort of key principles, not surprisingly, these, no matter how, which way you slice these kids, you're going to see kids who have, again, increased mortality, increased healthcare use, and increased outpatient use. Joanna and her team have gone on to do some really lovely work focusing on rural-urban disparities for these children, some really neat thought around network analysis, so sort of understanding networks of providers for these kids, and sort of, again, looking at complexity across the spectrum of care, not just the inpatient setting. And again, before I dive too much into thoughts about the inpatient setting, I want to make sure I give a shout out to our outpatient colleagues. So again, folks who are just doing some great work in this area include David Ming, who's at Duke, who's using large data in North Carolina to do some really nice utilization descriptions, as well as service delivery. David Bergman, towards the end of his career, did some really nice work using the FIS data set to evaluate outpatient care models. And Ricardo Mascara, who's at UT Houston, has done some sort of has a, I guess he calls it an enhanced medical home, but it's sort of a boutique service. He's a pulmonologist and he takes care of kids who have vents at home. And he's been able to demonstrate in trials some really lovely benefits to sort of this boutique model. And this is not just in the outpatient setting, but is also in having that service go into inpatient consultation as well as telemedicine. So again, super exciting work. So I'm going to pivot now and talk a little bit about clinical considerations. I know not everybody is as into the data or the algorithms as I am, so I'm hoping that the rest of you will get something out of this talk. And I'm hoping that I'm going to sort of ground this in some cases and sort of some anthropologic work to help, I think, describe some of the consistencies in experiences for patients and for providers who are taking care of them. So I think I already mentioned, I first gave this talk in about 2021. I had just made a move from Seattle to Children's Hospital, Los Angeles. My first day was April 1st, 2020, which was, in hindsight, possibly the worst first day of a job, but could possibly pick. But so I gave this talk. This is based on an actual child who's neither pictured near here nor is named Ebenezer. I have to say that because Children's Hospital Los Angeles has asked me to say that. But it is based on a child whose actual lived experience was at Seattle Children's. But I'm hoping it's probably not entirely unfamiliar to many of you in the room who may or may not be hospitalists, but certainly as trainees and certainly as subspecialists, I hope that some of this story resonates for you, or you can see this in a child that you may have taken care of. So this quasi-hypothetical child underwent myelomeningocele closure, so sort of was a known child with myelomeningocele before birth. Came out, sort of had all kinds of specialized care, and underwent initial closure, and then sort of declared himself to be shunt dependent, or to require a shunt. That was placed on day of life 4. That was followed by difficulty maintaining saturations. And this sort of extended beyond sort of apnea of prematurity, and sort of kept on going and kept on going. And then finally, we sort of did a bunch of diagnostic tests and realized that he had central hypoventilation, which then resulted in a tracheostomy. And because of all this sort of early life that was fully medicalized, recognize that this is a child who is not really going to be able to thrive with oral feeds. So an NG tube was placed, and as is not infrequently seen, fast forward, to this child being on my service around 3 or 4 months of age, and we're doing a lot of trach teaching. We are trying to sort of work with the family to get ready to go home for the first time with, basically bringing a little mini ICU home, and that's sort of, I think, it obviously that doesn't happen to a lot of children, but it does happen to a lot of the children that we're taking care of in these tertiary and quaternary care hospitals. This was, I have to give a shout out to my mentee, Carolyn Foster, who first clued me into this. This was some really nice work that was funded by the Lucille Packard Foundation. They funded some anthropologists to go talk to families of children with medical complexity. And they put together some diagrams. I'm going to refer to them throughout this talk because I found them to be really helpful for me in talking to trainees and in reflecting on my own lived experiences. But the concept here is that there's a similar trajectory of illness that these families describe. There's a initial period of sort of pre-diagnosis. So in Ebenezer's case, sort of this child is known to to have myelomeningocele, and there's sort of this array of presentations that the child might have, and there's sort of that uncertainty or sort of lead up, the family sort of holding their breath. And then there's this crisis phase where the child is undergoing diagnosis and treatment. So I would sort of, in the story that I was relating about hypothetical child Ebenezer, I sort of think that 4 months of being in the hospital and sort of having one incident after another sort of issue or after another declare itself, to me is sort of that crisis phase. And then there's this reentry phase, which in my mind is sort of that period of time where we're getting this family ready to go home with their ICU in their bedroom. And then our families move into sort of a new normal. They sort of get get a grasp on their child's illness, and they sort of move through waves of maintenance and then sort of complications. So there's can be sort of cycling or an up and down, again, back to the analogy, some waves basically. And then very predictably, our families describe a real crisis when these children hit sort of young adult phases. As I think once you get the hang of the pediatric system, you get the hang of the pediatric system, and then you sort of have to go into adulthood and you have to deal with a whole other set of systems and demands. This is a framework that I also found helpful. I think, again, back to myself as an intern hating taking care of children with medical complexity. I think that I always, part of what I came to recognize was that I was always the person in the room who knew the least. Like I was sitting in these rooms and these families knew so much more about how to take care of their kid. And a lot of times they were patient with me and occasionally that they weren't. And it just sort of made life hard as a trainee. And I sort of came to realize, oh, those are these activist parents over on the right-hand side of these diagrams. Like, so these are the folks who are seeing themselves as an active part of the healthcare team. And they're hopefully going to be using their expertise to help others and really advocate for everybody. But in the meantime, they might make my life really hard as a clueless intern. Me only, none of you are clueless interns, just me. But they sort of can really be challenging, or as a clueless attending as well. I think it sort of also helped me understand I've definitely had this lived experience of sitting in a room with someone like Ebenezer's family who might be sort of just experiencing this whole wash of new terminology. And sometimes you might feel like I felt like I was talking to someone and it wasn't landing, like I wasn't effectively communicating, and probably because they were really overwhelmed and pretty vulnerable on this sort of left side of the slide. So sort of understanding that there's a continuum of caregiver experience, and also that the caregivers might, because they're experiencing waves, they might be an advocate or an activist during one phase of illness and then experience a setback and sort of slide back into another part of this conceptual framework. And sort of understanding that, I think, has been really important for me as a care provider. So with that grounding, I'd like to move now to share with you my excitement about emerging research. And I'm focused again, the caveat, my interest is in inpatient care for children with medical complexity. I know there's a lot of great work that's being done elsewhere. So if you just bear with me and let me share my excitement about what's going on in hospital medicine, I appreciate it. So I thought I would focus a little bit on organizationally first on what the medical issues that Ebenezer might expect to experience in the inpatient setting over the coming years, and then move to the social issues. And my concept here is to really not provide an exhaustive talk. I think any of the people whose work I'm reflecting on would be delighted to have the opportunity to come and talk to you about their own research programs, but more to sort of give you an amuse-bouche or sort of whet your appetite for what I think is going to be coming in the next decade or so, because I hope we're kind of done describing these kids and sort of the utilization that they have. And I hope we're going to start moving into like some real tangible recommendations about how to best take care of them. All right, so going back to Ebenezer, I think I've reasonably convinced you that he needed a trach, that he left our hospital with a NG tube, and he's got a shunt. It's probably likely that he may go on to continue needing that NG feeding tube, and at some point there may be a decision made that he needs a gastrostomy or permanent feeding tube, and he may eventually, as he gets older and moves into sort of further down the age continuum, that he might need a baclofen pump after developing some tone issues. These devices are amazing. I'd like to talk about shunts all the time. They're amazing. They have sort of changed this landscape for shunts. Pediatric hydrocephalus allow kids to survive, but they present sort of new problems. They themselves become problems. So this is some great work that's been done by the group in Wisconsin that sort of starts to describe in a single center way the care required by device complications. For those of you who practice in the ED, you probably wouldn't be surprised to see this, but sort of this paper found that 17% of hospitalizations and 31% of ED visits were associated with device complications. I don't think that's, again, a particular surprise, but sort of underscores that we really need to be familiar with these devices and hopefully coach families on how to use them better. Moving into one specific device, the trach. So Ebenezer has a trach. He's got this artificial opening down into his lower airway. And this comes with problems. This comes with repeated issues with respiratory illness. It can show up as tracheitis, as pneumonia, or as sort of complications of the trach itself in terms of either emergency care or sort of upper airway obstructions with granulomas and whatnot. So Katie Forster and I are actually part of a later study that I'll talk about. But in the meantime, our shared colleague, Joanna Thompson, who's at Cincinnati Children's, has been doing some really nice work on children with neurologic impairment. She's been interested in identifying hospital management practices and working towards coming up with care recommendations for management of respiratory illness in children with NI. These are some of her papers. So a paper that we participated in Seattle that's about airway clearance. And again, using sort of input from a Delphi approach for recommendations on pneumonia management. So this was what I meant to allude to with Katie, and patients here, I believe, are involved in Dr. Chris Russell's work. Chris was my colleague at Children's Hospital Los Angeles before he abandoned us and went to Stanford a few years ago. He's been funded by the Gerber Foundation as well as AHRQ to better understand the management of bacterial tracheostomy associated respiratory infections, which he affectionately calls B trains. I think he had some really great he and his team had some great presentations at PAS. So if you went recently, you might have heard them. And he is busy publishing some really great work. And you're going to hear more from him in years to come. I think his general interest is probably going to land on trying to promote more prudent antibiotic use for these infections and probably some more diagnostic accuracy as well. I'm a shunt fan myself. So I would not be myself if I didn't point out that Ebenezer's shunt is likely to fail in the coming years. Shunt failure rates are improving, I'm delighted to say, over the course of my career, but are still at about 40 to 50% shunt failure over a 2-year period. He will almost certainly at some point require surgical revision and may or may not develop an infection, which is where my work comes into the game. I have been funded by the NINDS to characterize the microbiota of CSF across the course of shunted hydrocephalus. I have the benefit of having had an R01 that's done being funded. So we are trying to get all these papers out, but we've been, I'll be talking more about these later. But we've been working hard on that microbiome. I've also had the privilege of working with Dr. Pollack, who's here, on a study that I term FIS+. We basically wanted to take advantage of existing variability in approaches to shunt infection prevention. Specifically, there was a period of time that the network that we're both a part of used intrathecal antibiotics, and antibiotic impregnated shunt tubing has sort of become de rigueur in the field, and we had an opportunity to use the FIS+ database to dig into the relative efficacy of these approaches in prevention of shunt infection, not just from an infection rate perspective, but also to better understand the responsible organisms, antimicrobial resistance, and costs. So we're still working on the third objective, but these are some of the papers that have been coming out of this work. And again, I'm prepared to talk a little bit more about that later today. But moving on with Ebenezer. So Ebenezer's got a neurogenic bladder, and he's almost certainly going to develop colonization with bacteria and potentially intermittent urinary tract infections. And this is where your own Katie Forster has is doing amazing work and to help us better understand what is UTI and what is not UTI in these populations with a focus on biomarkers. So a shout out to you and your great work. And one of our only basic scientists. So thank you for that. Kids, particularly who are nonverbal, can present with irritability that can be really frustrating for them, for their families. I think there's some nice focus as our federal mechanisms have sort of promoted more patient-centered work and sort of more collaboration with families. I think that this has been an area of increased focus, deservedly so. This is some work that we've published in Hospital Pediatrics. It's sort of a framework to think about working up kids with irritability who might not be able to sort of effectively communicate where things are bothering them. So I think there's going to be more in this to come. I'll allude to this a little bit more again later, but again, as an inpatient pediatrician who likes to care for children with medical complexity, I've had a lot of people sort of come up after one of my talks and be like, but like, what can I actually take home from this talk that I can be doing? So I thought I would throw this in. Probably got a little touch of the OCD, and I really like to take advantage of kids like Ebenezer coming back into the hospital to do some house cleaning and really sort of take advantage of all the resources we have in the inpatient setting to help families sort of level up care that might sort of get overlooked or may may get deprioritized because of other issues going on while we're in the inpatient setting. So I like to sort of advocate to use the inpatient setting as a time to think about housekeeping. So I'm the queen of Miralax, or love to ask families how about their children's bowel regimen. And I actually have to say, my pearl to my trainees is if you ask these families about sort of feeding regimens and bowel regimens, I kind of think families like you because they are often spending a lot of time thinking about this. So pro tip. I also like to take advantage of the expertise of our dietitians, nutritionists, and other GI staff. If a kid is coming in and is requiring tube feeding, it's a great opportunity to sort of brush up on nutrition, make sure that the growth curves are where we want them to be. I love leaning on our pharmacist colleagues to sort of take a look at these medication lists. These can become sort of very cluttered or really hard to sort of manage at home. So this can be an opportunity an inpatient stay can be an opportunity to clean up the med list. I love taking advantage of our supporting staff in terms of care coordinators. We have team coordinators who can sort of help schedule appointments. So I love going through all the subspecialists and make sure that kids have been seen at the cadence at which they were supposed to be seen. This is an amazing opportunity to address equipment issues and plow through insurance issues and identify any social work needs. I like to think about discharge early. I mean, I think this is kind of an adage in hospital medicine, but I think you can never start too early with a child like Ebenezer, really thinking about what's needed at home. It's a great opportunity to think about immunizations. It's very typical to have our families voice some concerns and vaccine hesitancy. So just be prepared to have those conversations. Don't budget 5 minutes for those conversations, I guess is what I'm trying to say. And then depending on the degree of neurologic impairment that a child might be experiencing, again, sort of anticipating some of this irritability or autonomic instability, sort of understanding that this may be on the way can be very helpful. Some of our most therapeutic conversations are talking with families about normalizing some degree of autonomic instability. So I'm going to move now to talk about maybe some of the social needs. And again, this is going back to that Lucille Packard, that ethnographic work that I was describing. And here again, I read these and sort of had some aha moments looking at these. The top line in red is meant to designate the resources that a patient and their families might need as they go through this sort of life course. And on the bottom in blue, you can see the resources that are available. And obviously the delta between those two is the gap. I sort of had this, again, self-awareness is everything, but sort of had this realization that I'm often sitting in that crisis area. And again, as I've sort of already alluded to with my checklist, see this as a real opportunity to sort of narrow the gap. I derive tremendous enjoyment from sort of helping identify issues and knocking through them and sort of helping provide those resources. But again, it's very typical that as our patients move into their new normal, they also experience can experience dramatic decreases in these resources. And they will, similar to everything else that I've said, experience these in waves. So just something to sort of be aware of and attune to. It's been a helpful framework for me. The other aha moment that I had looking through this work was this, where again, sort of helped me with my own self-awareness. The x-axis represents system friction and the y-axis represents urgency. So you can sort of see those of us who practice in ERs, ICUs, and inpatient setting tend to be in the more urgent category where we experience less system friction. So again, this is sort of what I was alluding to. I like to encourage trainees to take advantage of all the resources that we have in the inpatient setting to help families narrow this delta or the gap in the care that they're experiencing. I will say it's also been helpful for me also as a parent of a child with special healthcare needs that there's a lot more friction that sort of is experienced as our families and their children sort of move to a more typical life and move out of the hospital and out into the community and into school. Their friction sort of increases dramatically, and their ability to access these resources can be very, very challenging. So I've sort of had to remind myself to give our families grace, and also to recognize that for me, part of why I like taking care of these kids is because I get more control. So again, this was a helpful framework for me. This is another representation. This was actually in the, I already spoke through this, so this is sort of another visual representation. I think the way that they described it was for the activist parent was the squeaky wheel that gets the system response. So I think you've probably heard that before. I think another construct that's been helpful for me, and this is, I think, something that I struggled more with earlier in my career, and I've come to appreciate more over time. I think that sometimes if a family or a child and their family is not going to experience a typical or so-called normal childhood, it can be sometimes hard or can feel disingenuous if you're sort of early in your career to sort of talk about, you might feel compelled to sort of talk about being very realistic about the outcomes. And I think that's important, but I think it's also really important to carry hope in these conversations and recognize, at least for me, sort of recognizing that I'm interacting with this family on sort of a long continuum of their lived experience, and they probably don't need me to reiterate sort of all the bad outcomes for their sort of diagnosis. And it's probably okay to sort of focus on the pieces of informed hopefulness, focus on opportunities for resilience and sort of opportunities for empowerment, and that you can that it can still be an authentic exchange, even if it isn't focused on sort of all the bad outcomes. I think that was sort of something I always struggled with. How truthful am I being with this family if I don't tell them everything that's in my head about what might happen to them? And I think I've learned over time that it's probably okay to not have to talk about all the things, but to anchor on pieces of hope or areas of improvement, and that can still be authentic, important exchanges. I've already alluded to this, and I think it goes without saying that those of us who practice in the inpatient setting see bad things happening all the time. These are bad things happen in hospitals. It's sort of by definition, and these are kids who are coming into the hospital a lot. So they have and will experience sort of bad things in our vicinity. Again, an area, thankfully, that some of our hospital medicine colleagues who are more courageous than me have chosen to wade into. So Pat Brady, who's division chief at Cincinnati Children's, focused his K Award on helping families identify sort of their emotional responses to their children's worsening illness and look at tools to sort of co-design tools to discuss those sort of bad outcomes as well. So this is some of the work. I'm not doing a great job of describing this, but the idea is that recognizing that children like this do deteriorate and that there is sort of there are ways that we can be actively engaging in conversations with parents and their families. As well, we can be working on trying to make the hospital a safer place for them. So some really great work. Dr. Khan at Boston Children's has been able to parlay her KO8 into an RO1. She's been very focused on family safety reporting, so it's been interesting to sort of understand we as providers have our concepts of what safety issues are, and she's been able to have some very interesting conversations with families about what their perceptions are. There's of course overlap and there are of course differences. So she's been implementing sort of implementation of a tool to work on family safety reporting. We have the privilege of working with her on this at Children's Hospital Los Angeles, so that's been fun to see from the sidelines. I've alluded to this many times, and I know you all do a lot of this, but there's a lot of coordination of complexity as children move from the hospital home and then back again. This was a care plan that we had on the medically complex child service at Seattle Children's, sort of intended to be a way to quickly and effectively identify sick plans for kids in sort of not all domains, but sort of the most problematic domains. We sort of came to realize that a lot of our kids had repeated problems in the same body systems over and over again. And half of the problems that our families experienced was communicating this to the ED or the ambulance, followed by the ED, followed by sort of various inpatient teams. So we had built these care plans. They were on paper so that families could hand them to ambulances, and we had them in portions of our medical record. I'm sure you all have similar tools. But my colleague Arthi Desai had a KO8 and an R21 that was really focused on taking those kinds of care plans and co-designing web-based care plans. This is sort of a little bit of a preview of what it has looked like as she has been developing it. It's a little bit similar, but a little bit different to that paper version. And she's been working on publishing sort of her work around this cloud care. Ryan Collar and his team at University of Wisconsin have been doing some great work around what they term the meds at home intervention. They've also done some fantastic co-design with patients and families, and they've chosen to focus their energy on medication administration and sort of record keeping. So they've had their tools are a little bit more focused on sort of documenting the delivery of the meds and sort of the feeds and that type of thing. So they've done some really nice work there and have a ton of stuff coming out. They're a fun one to watch. Carolyn Foster is my dear mentee in Seattle, has moved on to Lurie Children's and has done some fantastic work on sort of clinical decision dashboards. She's very interested in home mechanical ventilation and just got a really great score on her RO1. So this is sort of intended to facilitate remote monitoring and sort of help pulmonologists make changes based on data that's being collected at home. So cool work that's happening there. Flory McCoy, who was my colleague when I was at the University of Utah, has also been interested in home-based monitoring. His tool is sort of My Child CMC, and he's been sort of more focused on Early or monitoring as a way to sort of identify children who are getting into trouble early. So the idea being if you're sort of passively collecting, in this case on the right-hand side, lots of heart rate, you might sort of get a sense that a kid's getting sick before they actually show up in your ED. Turns out families also do a really good job of telling you when their kids are getting sick. So anyway. So Ebenezer will almost certainly, while he might have unplanned admissions, he's almost certainly going to have some planned admissions. I've already alluded to his NG tube. At some point, a decision's probably going to need to be made about gastrostomy placement. There's the forever discussion about with or without a fundo. Should there or should there not be a GJ tube? I like to allude to the Canadian Mafia shown on the right here. So Kate Nelson in particular has been doing some great work understanding decision-making patterns. Unfortunately, in Canada, they tend to go to GJs first, which I just think is fascinating, and also just reminds you that you've seen one place. But I think there's a lot of opportunities here to better understand decisions around gastrostomy tubes. They're also doing a really cool complex care trial up there, so stay tuned for more about that. Ebenezer may go on to develop scoliosis. At some point, a decision will need to be made about spine fusion surgery. And my colleague Jody Lynn, who I was involved in mentoring her as she moved from Stanford to Intermountain. She's also has focused her K-23 on shared decision-making for children with neuromuscular scoliosis and is busy writing her R01s around a tool that she's been developing. So again, some really interesting work around caregiver values and preferences and sort of having those be collected in a way that informs surgeons and hopefully improves the quality of those discussions. So, should he develop hypertonicity, a decision might need to be made, at least at first, about tone medications and eventually about possibly a pump. I again turn to our Canadian colleagues for inspiration. So they have done some great work. Catherine Diskin specifically has done some really nice work developing a list of top priorities for these children. So this is the paper and this is the list. Many of these topics we've already talked about today, but these are sort of, in my mind, a much more sophisticated call to action than the first paper that I was sharing with you at the beginning of the talk. So we're excited to sort of make progress in the next decade in these arenas. Also, a shout out to Ryan Collar and his team that has, and this is a little bit of a busy slide, but just a reminder that we need to move past utilization and look at more health factors, even possibly go so far as to look at policies and programs and really try to step back outside of even just this narrow focus that I've been talking about inpatient care and really look at the whole child and the whole context. Just wanted to recognize that the importance of children with medical complexity has been recognized in PHM core competencies. So this is a core part of who we are as hospitalists, not just in the US, but also in Canada. So yay, we'll continue to grow this. I'm also would be remiss if I did not give a plug at our journal, Hospital Pediatrics. Again, this is an issue that we put together in August 2020. I was thrilled to be able to fill an entire issue with complex care articles. And since then, we've been able to support an average of about one article a month on children with medical complexity. We really wanted to be a home for complex care papers that are focused on the inpatient setting. So we encourage you to, if you're interested in publishing in this area, to think about us. And I would be remiss if I did not give a shout out to my pal Amy, who I thought had a lovely quote. I hope that you're seeing that disability should not just be seen as a tragedy or a problem to be solved. It's a natural part of the human experience. It's certainly a natural part of the experience of pediatric hospitalists, and I'm really thrilled to see what we're able to accomplish in the next decade in terms of research and education and clinical care for these patients and their families. Thank you again, and I'm happy to take any questions.